Dr. Ken Landau. Thanks for watching. Let's talk about community-acquired pneumonia. Community-acquired pneumonia, infection in the lungs, causes significant morbidity and mortality. More than 5 million people are going to suffer pneumonia this year. Fortunately, 80% or more are going to be treated in their homes. They're not going to require hospitalization. But still, 1 million people are going to be hospitalized because of pneumonia. Actually, pneumonia is still the #1 cause of death from infectious diseases in people who are over age 65, causes more than 55,000 deaths, 8th leading cause of death when you combine pneumonia and influenza. Often the diagnosis is not made, people misdiagnose, mistreated, and unfortunately it's underestimated in the number of cases. Historically, we've characterized pneumonia as community-acquired pneumonia when you're carrying out your normal day-to-day activities, and the nosocomial pneumonias, those kind that you get because you've been hospitalized or you've been on a ventilator, you have some interaction with the healthcare system. The importance is that those individuals have a greater chance of developing their lung infection, their pneumonia, because of multi-drug resistant organisms. So that's a major distinction. So what is community-acquired pneumonia? That's when you present with acute symptoms, you have the signs of a lower respiratory infection, you don't have any other obvious cause, and you have a test like a chest x-ray that shows that there is a new infiltrate. That gives us a definitive diagnosis. Well, typically we treat people who have pneumonia before we have any other laboratory tests, no cultures, no blood tests, just the history, the physical examination, and oftentimes a chest x-ray. And we get the appropriate kind of antibiotics. And because we do that, we can decrease the misuse of antibiotic and decrease the likelihood that we're going to use a broad-spectrum antibiotic. So now we can decrease the bacterial resistance and we prevent the side effects. But we have to realize that the organisms that are most likely depend on where you happen to be in the world, where you happen to be in the country. There are certain organisms that tend to grow in certain areas and cause more problems, and those organisms may have their individual resistance patterns. So if you get a strep pneumonia in New York, might not have the same resistance pattern if you get strep pneumonia in Los Angeles. Well, we also have a U-shaped distribution as far as the age is concerned. Greatest risk are children less than age 5 and adults over age 65, more common in men than women. The overall rate is about 12 in every 1,000. Raises to about 20 in every 1,000 in people who are senior citizens. Everyone's at risk. We can define the risk sort of by looking at some of the risk factors. So if you're more than age 70, if you have decreased cough, or if you have decreased gag reflex, or if your body is unable to produce the antibacterial substances just because of the wearing out of your innate immune system over a period of time, you have a decreased what we call toll-like receptor response. Or maybe because you're alcoholic, or you have asthma, or you're immunosuppressed, or you're institutionalized in a nursing home. Or maybe you have dementia, or seizure disorder, or heart failure, cerebrovascular disease, you've suffered a stroke. You use cigarettes, tobacco smokers have higher risk, COPD patients. If you have HIV, or sometimes people just have community-acquired MRSA, methicillin-resistant Staph aureus, the organism Staph aureus, and it happens to be resistant to methicillin, which is a type of penicillin derivative, and it happens to be growing on your skin. It can grow on your skin without causing any kind of problem, and in those people, grow on the skin, it causes an infection, an abscess. Those people seem to be at greater risk for complicated pneumonia, and some people are just genetically predisposed. So the risk for having these resistant organisms could simply be because you have heartburn or gastroesophageal reflux disease, GERD, and you're taking omeprazole or one of those other PPI drugs. And what they do is they suppress the acid production in your stomach. And that allows other kind of bacteria to overgrow that you can then swallow and get into your lungs. Or if you have severe COPD or bronchiectasis, or if you're non-ambulatory, you're confined to bed, or people have higher chance of resistant organisms if they've taken antibiotics within the past 3 months, or if you've been hospitalized for at least 2 days within the past 3 months, then you're at greater risk for having a resistant organism. Also, too, if you're receiving tube feedings or if you're immunosuppressed. And community-acquired pneumonia, people have a fear of MRSA, methicillin-resistant staph, but it's relatively unusual in the community. Yet, so many people with pneumonia are being treated with fancy kind of antibiotics that are really not appropriate for the average individual who has a community-acquired pneumonia. Now, you think that it's easy to find the cause of pneumonia, but it isn't. So in spite of all of the tests that we do, about 50%, 1/2 of people with pneumonia, we can't find the reason they had the pneumonia. In many cases, it's bacterial, but in as many cases, it's viral. And of those people who require hospitalization, it's more often viral than bacterial. And it's now a special problem with the coronavirus, or COVID-19, especially in young adults and senior citizens, but it also could be due to a fungal infection or a protozoal infection. Actually, the Centers for Disease Control looked at people who were in the hospital. People who had community-acquired pneumonia required hospitalization, and they found that viruses were the sole cause in 1/4 of the cases, and viruses in combination with something else, typically bacteria, were the cause in at least 1/3 of the cases, and bacteria all by themselves only caused about 10 or 11% of cases, and that means that half of the cases, fully investigated, no idea why they had their pneumonia. Now, if we do a bronchial specimen, and we get some fluid directly from the lungs, we have about an 80% chance of finding it positive. But if we just swab the nose and swab the throat, chance of being positive for whatever the etiologic, the causative agent is, only about 20%. And interestingly, there's the sensitivity of the test. So major hospitals have often perfected some PCR tests. So, for instance, for rhinoviruses, some institutions find that their rhinoviral test will be positive, but if they ship it out to some commercial laboratory, the test will be negative. Same specimen, positive in the hospital, negative out of the hospital. And now we have the newly realized cause of pneumonia. So we have all the coronaviruses, the SARS, the MERS, and now the COVID-19. Now we have a slightly increased risk of the community-acquired MRSA, and now we have new viruses like the metapneumovirus. We have the bocavirus. Bocavirus is a little controversial whether it's the cause or whether it's just a tag-along organism. So of the identified causes, strep pneumonia, that used to be the major cause, only causes somewhere between about 10 and 70% of pneumonias, depending on the age, depending on where the person happens to be located, depends on a variety of factors, patient factors. But Haemophilus influenza cause about 10% of pneumonia. And now we have what are known as the atypical bacteria. They cause about 1/4 of all pneumonias. That's Mycoplasma pneumonia, Chlamydia pneumonia, Legionnaire's type pneumonia. Oftentimes those are called walking pneumonias. But probably 20–30% of the people with identified pneumonia are going to be caused by viruses. And it's not just the coronavirus. Influenza virus, parainfluenza virus, RSV, respiratory syncytial virus, or rhinoviruses. Actually, some reports now show that rhinovirus and influenza virus cause more pneumonia than the strep pneumonia. And it all depends whether you're going to need routine care, either treat at home or treat in the hospital, or if you're in the intensive care unit. If you're in the intensive care unit, it's more likely Legionnaire's disease or Pseudomonas or Enterobacteriaceae, or maybe you have an extended beta-lactamase organism, or maybe MRSA or Klebsiella, something fancy. So it seems that the people who are severely ill have other kind of causes than the people who are either not severely ill or require just minimal hospitalization. Now, the incidence of strep pneumonia has gone down because of the vaccination in young children, but that means that the incidence of Mycoplasma and Chlamydia pneumonia has gone up. And so, too, have some of the non-vaccine types of strep pneumonia. So there are more than 90 different serotypes of strep pneumonia. And depending on which particular vaccine you get, the one in children counts for 13 serotypes. The one in adults counts for 23 serotypes. So there are a lot of serotypes that can cause pneumonia that aren't covered by the vaccine. And in 10 to 15% of the people, we have polymicrobial conditions. So we have a combination of the typical and the atypical organisms, or the bacteria and the viral organisms. And actually, strep pneumonia or Staph aureus, the MRSA, they can complicate influenza. And then we have some peculiar organisms that can occur when people aspirate. So normally, when you swallow, the fluid goes down in your esophagus, down to the stomach and beyond. But sometimes you can aspirate and the fluid goes down your respiratory tract. And then, either days or weeks later, you can develop a pneumonia. That occurs specifically in people who have excess alcohol intake or drug overdoses or seizures. People who have significant gingivitis may lead to some problems in the lung, and that frequently leads to complications like abscesses and empyemas and effusions. Culture, everyone thinks that culture is such a great idea, but culture frequently is negative, oftentimes because it's a viral organism and we don't do very well culturing viruses, or we have a fastidious organism, an organism that doesn't really require a lot of oxygen. And our tests typically require the organisms that do require oxygen. So we culture people, we do the cultures if people fail to respond to the antibiotics, or if they're at increased risk, or if they don't have a spleen, maybe because they have sickle cell disease, or maybe because the spleen was removed because of a motor vehicle accident, people who are immunocompromised or have AIDS, people who have alcohol-associated disorders, people who have sepsis. Those people need cultures. Well, what's the protection you have? Why doesn't everybody get pneumonia? We are all exposed to a lot of organisms, but we have our immune system. Our immune system makes antimicrobial substances. And then we have the normal flora that's present in our throat and our nose, and in our respiratory tract, and it crowds out some of the pathogens. Then we have the hair cells in the nose, and we have the turbinates, and we have the mucus that the cells produce, and we have the little micro hair cells, the cilia, that push things out. Then we have the epiglottis that closes off the respiratory passageways, and we have a cough reflex if something gets down into the lungs. And then we have the branching pathway of the tracheobronchial tree. And then the final method of protection is a type of a white blood cell. We call it an alveolar macrophage, way down in the air sacs. So under normal circumstances, multiple organisms can gain access in, but they're taken care of. But sometimes we get too many organisms in, like we aspirate too many. And you can aspirate, especially if you're older, during your sleep, if you have an altered state of consciousness, you drank too much, you took too many drugs. So normally, it's those alveolar macrophages. They're the last line of defense. They initiate an inflammatory response when they get overwhelmed. And that inflammatory response, not the organism itself, but the inflammatory response, is what causes the symptoms that you call pneumonia. It causes the clinical syndrome of pneumonia when you start releasing some of the substances that the body's immune system uses to combat the organism. So the IL-1 and the tumor necrosis factor and the IL-8 and the GSF, all sorts of substances. And what they do is they cause a localized respiratory distress, then they cause a more acute respiratory distress that could be generalized. And that causes edema in the air sacs, fill with fluid. And when they fill with fluid, and then oftentimes with red blood cells, and then sometimes with white blood cells, then there's not enough room to get the oxygen in. And if you can't get the oxygen in, and you're supplying the blood to the area, the blood isn't getting the oxygen, and now all of a sudden, your lungs are stiff, your lungs are full of fluid, your lungs are not compliant, and you're short of breath. You're short of breath so much so that sometimes you can't even speak a full sentence. You're gasping for air as if you've just run a mile. And you have a cough. And the cough could have some mucus, or it could have some pus, or it could have some blood tinging. And sometimes people have non-productive coughs. And sometimes people have a lot of blood. That tends to suggest the MRSA. You could have fever, oftentimes with chills and sweats. You can have an increased respiratory rate, increased heart rate. Or some people don't have any symptoms related to the chest at all. If the pleural cavity surrounding the lungs is affected, infected, Then you might have some pleuritic chest pain, pain that's associated with taking a deep breath in. And about 20%, or 1 in 5 people with pneumonia are going to have some gastrointestinal symptoms, some nausea, some vomiting, some diarrhea. Others are going to have fatigue and joint pain and headache. All depends on the organism. Some of the pathogens are going to cause a dry cough, not have much fever. For instance, Mycoplasma pneumonia might actually begin as an otitis, a middle ear infection, or pharyngitis. Sometimes it can progress to cause a skin rash or hemolytic anemia, but oftentimes it's called a walking pneumonia. Legionnaire's disease in some people can be severe but not really have any lung-related symptoms. So people might complain of headaches and confusion and diarrhea and symptoms associated with a low sodium. And the elderly oftentimes don't have any chest-related symptoms. They don't even have fever necessarily. They might present with an altered state of consciousness, delirium, confusion. They might have gastrointestinal discomfort, abdominal pain. And for those individuals, the diagnosis is going to be delayed. It's going to be delayed in a lot of people if they have less serious pneumonia, if they drink too much alcohol, take too many the opioids. Also going to be delayed in people who are taking antibiotics for other purposes that aren't really appropriate, but can suppress the bacteria for a while. And people who are taking the non-steroidal anti-inflammatory drugs that keep the temperature relatively normal, people who are taking the corticosteroids. So the presentation can be typically with the strep pneumonia pretty fulminant. You have a violent onset of the disease, but the severity can range anywhere with pneumonia from being very mild to being fatal. And as an interesting side effect, there are a significant number of people who will develop some cardiovascular complications. And when you develop a cardiovascular complication due to the pneumonia, about 90% of the people who are developing this acute coronary syndrome that looks like a heart attack, well, it's going to occur within 1 week of the pneumonia, but the risk stays elevated for about a year, and that's because of all that inflammation that tends to cause the blood to coagulate inside the system. And that's especially prominent in people who have had a history of a heart attack or a congestive heart failure or arrhythmias. So the physical examination varies depending on the severity of the pneumonia, depends on the consolidation inside the lung. So it's going to be different between viral infection and bacterial infection. Depends on pleural effusion. Typically, people are going to have an increased respiratory rate. They're going to use the excessive muscles of respiration in the neck and between the ribs. The chest, when the doctor percusses it with the finger, well, it's going to be somewhat dull, listens to the breath sounds. They're going to be somewhat crackly. And interestingly, viral pneumonia has similar presentation to bacterial pneumonia, and clinical criteria can't differentiate the two. And oftentimes it's difficult to differentiate them on the laboratory or on the chest x-ray, unless we can identify the particular pathogen. But when you have a viral infection, viral pneumonia, typically the white cell count isn't really elevated. It's normal or even suppressed, variable fever. Sometimes people have upper respiratory symptoms. The frequency, pretty much the same between bacterial and viral infections at the present time. The outcome also is pretty much the same between viral and bacterial. Now, with viral pneumonia, the standard cultures aren't much good, and the typical tests that we've used in the past, the immunofluorescence and the serology and the viral cultures, they've given way to the new test, the real-time reverse transcriptase PCR test. That's much more sensitive, and it's available, but only for specific viruses. First, we have to identify the virus, then we have to create the test for that particular virus. But fortunately, we now have multiplex PCR, so we can test for a whole bunch of organisms at one time. But the timing is important. So we can find a test that's positive one day, but if we do it a day later, we might find the test is negative. Complications of pneumonia. Well, it could be respiratory failure. Could be that if it's caused by a strep, the strep can get into the bloodstream and cause sepsis throughout the body. That's a major cause of sepsis, bloodstream infections worldwide. That can lead to failure of multiple organisms, the coagulation inside the blood, lead to shock, cause worsening of coexisting illnesses, and in some people can lead to lung abscesses, especially if you're cause was aspiration because you were elderly or because you were drinking too much alcohol. Some people get pleural effusions, and other people get metastatic infections. So you start off with infection in the lung, but then it spreads. It can go to the brain and cause an abscess, go to the heart and cause endocarditis. The mortality, well, it's limited in people who aren't severe enough to require hospitalization. So if you don't need hospitalization, the likelihood of dying from pneumonia is less than 1%. If you need hospitalization, it goes up to somewhere between 4 and 20%, depending on a variety of factors, including your health factors and the severity of the illness and the organism. And then if you require intensive care and you're in the ICU, well, the death rate can go up to 40 or 50%, increased, of course, with age. The older you are, the greater the risk. What kind of comorbid diseases? Are you a frail elderly individual? You're at higher risk than an otherwise healthy elderly individual. Do you have cardiovascular complications? Do you have a history of heart failure? And now you have pneumonia on top of it? And what's the severity of the initial disease? But not all that looks like pneumonia really is pneumonia. It might be just a bad case of upper respiratory infection or acute bronchitis, or maybe you have an acute flare of chronic bronchitis. But some people don't have infection at all. What they really have is heart failure or pulmonary embolism, a blood clot in the lungs. That can cause the same kind of symptoms. Or maybe you have an allergic reaction, a hypersensitivity pneumonitis to an insect sting, or due to a food that you ate or a medicine you took. So the standard laboratory tests, we check the white count, we check markers of inflammation like the C-reactive protein. There's another test that supposedly differentiates bacterial from viral infections. It's called the procalcitonin. It's a blood test. And if it's elevated, it's supposed to suggest a bacterial infection. And when it comes down below, say, 0.1 micrograms, well, then you could discontinue the antibiotic. However, there's argument about whether the test really is as good as people assume. The old-fashioned serology is not very helpful because it takes about a month, because you have to do not only the acute specimen, but you have to do a test a month later. Well, you have a gram stain. You can stain and look at the sputum, but that really doesn't often give us the direct answer. But what it can do is tell us if we have a culture that's good enough, a specimen that's good enough for culture. And then we can culture, but the answers on the culture aren't necessarily definitive, because you can have strep pneumonia under normal circumstances. You can have staph under normal circumstances. So we have to decide if the organism that we find is really causing the mischief, or if it just is hanging out and just staying around for a short while. Blood cultures, typically they're not very helpful. So we tend not to do them. But if people are at higher risk because they have a low white count, or they don't have a spleen, or they have a complement deficiency, a genetic deficiency, or they have chronic liver disease from drinking too much alcohol, then those cultures might be appropriate. We can test for urinary antigens. If you have a strep pneumonia, if you have Legionnaire's disease, you're going to have a certain kind of an antigen that's present in the urine, and we can detect that. That's relatively quick to detect that in about 15 minutes or less. You can do a chest x-ray. Chest x-ray, typically a two view, one from the back to the front, one from side to side. But it's not 100% accurate. Less accurate if you're bedridden, or if you're obese, or if you have severe immunocompromise, or if you have a history of already having an abnormal chest x-ray. So CAT scans are sort of getting to be the in thing. They're more accurate for diagnosing the lung consolidation, and they can even reveal if a person has some kind of an alternative diagnosis, but they're more costly and they expose you to more x-ray, but they can exclude the pulmonary embolism, and they're sort of specific for coronavirus or for fungal lung infections, or they can detect pneumonia when a person is thought really to have just a flare of the COPD. They can determine what we call an occult pneumonia, or people with cavitary disease, or if people have swallowed something and they swallowed it and it got into the lungs, and then have pneumonia behind that, or if they have a tumor and behind the tumor they get a pneumonia. That can be detected on the CAT scan that probably wouldn't be able to be defined on a regular chest x-ray, and sometimes an ultrasound examination is good. Well, once you present to your doctor with what looks like it might be pneumonia, then you have to decide, you and the doctor, whether you get treatment at home or do you need the hospital, or do you maybe need the intensive care inside the hospital. And there are a variety of manners that we do that. There are some questionnaires like the Pneumonia Severity Index and the CURB 65. CURB 65 is an acronym. So that stands for C is for confusion, U is for the urea, if the blood test showing the urea is elevated, the respiratory rate is the R if it's more than 30, and the B is for blood pressure if it's less than 90, and the 65 is if you're over 65. So if you score 4 or more points on that test, you've got about a 25% chance of dying of your pneumonia. And there are similar questionnaires to determine whether you need intensive care if you're in the hospital. And some of the things that might lead to suggesting that you're going to deteriorate are you have involvement of multiple lobes of your lung. Maybe your oxygen saturation in your blood is very low, it's less than 70, or you're acidotic, or you're confused, or your respiratory rate's more than 30, or you have low albumin level and low white blood count, maybe low platelet, low sugar, and low sodium. Those all give us a hint that you've got really severe disease. Well, what kind of therapy should we begin? We have to take into account a variety of factors. We have to cover the possibility of strep pneumonia, even though most people have been vaccinated against it, but some haven't. And in some people it's worn off. And we have to cover not only the strep pneumonia, but also the atypical pathogens, the Mycoplasma and the Chlamydia and the Legionnaire's disease, Legionella. So we use a combination oftentimes of beta-lactam antibiotic, that would be a drug like amoxicillin, and then often combine it with a macrolide, that would be azithromycin, a Z-Pak, that sort of thing, or a clarithromycin, or we could use a respiratory fluoroquinolone like Levaquin. So there's a debate about whether we need really dual coverage, because if we use the macrolides, that could increase the risk of cardiovascular problems. We use the fluoroquinolones, that could increase the risk of your rupturing a tendon. So for people who have the typical, what appears to be low risk community-acquired pneumonia, beta-lactam antibiotic, the amoxicillin by itself probably is okay, and if you have more severe disease, then you need the combination. So the choice of the antibiotic, it ranges, as I said, depending on where you are and the philosophy of the doctor. There are lots of guidelines, and the guidelines would suggest a macrolide alone might be sufficient. So taking either the azithromycin or clarithromycin, maybe taking doxycycline by itself, or taking amoxicillin, that might be sufficient. But if you have more underlying health problems or you're more at risk, then we use fancier combinations and we use more antibiotics. So how long do you need the treatment? Well, if you seem to be doing well after about 3 days and you had low severity pneumonia, all you need is a 5-day course. If you had more severe pneumonia but you still improve and you're showing signs of stability after a couple days, 7-day course. If the infection goes out of the pulmonary cavity, then probably you're going to need more prolonged course. So once you start the antibiotic, you should start getting better within 2 to 4 days. The fever should come down, the white count should come down. Oftentimes we do a repeat chest x-ray in 1 to 3 months to make sure there wasn't any other underlying cause that we didn't originally find. If you happen to be elderly, we do that after about a month. We reevaluate people at 3 days or sooner because we want to make sure that we're not missing some sort of an underlying condition that mimics the pneumonia. We also want to make sure if it's a community-acquired pneumonia that you don't have drug resistance, you don't have a lung abscess, or that we're not giving you the wrong drug. Or maybe you're taking the right drug, but you're taking it at the wrong dose, or maybe the right drug, but the wrong frequency of administration because you're sort of lackadaisical about taking your medicine. Or maybe you have an unsuspected pathogen. Maybe you actually have tuberculosis or one of those methicillin-resistant Staph aureus infections. Or maybe you really had a hospital-acquired infection, or maybe you had a viral pneumonia. Actually, somewhere between maybe about 2 and 10 to 12% of people who are treated in the hospital for pneumonia and are released are going to be readmitted within 30 days. More than half of the time it's going to be due to some underlying comorbid disease that you had at the time. Maybe it was heart-related or pulmonary-related or neurologic episode. And then in some people, they can develop a new onset pneumonia, but in many cases it's treatment failure. The pneumonia wasn't really adequately treated. Maybe you were unstable at the time of hospital discharge, because after all, there's a tendency to get you out sooner the better, according to the hospitals and Medicare nowadays. Or maybe you were just older, you had impaired functional status. Or maybe the recurrent pneumonia that you have is really because you have lung cancer or cancer metastatic to the lung, and you had an infection behind that, or you have tuberculosis, or you had the foreign object that you swallowed that got into the lung instead of down into the intestine. Maybe it was because you had unrecognized immunosuppression. And now we're finding an increased resistance of the strep pneumonia. Find that in the elderly and people who recently treated with some kind of antibiotic. Maybe they took amoxicillin because they had a cold, or what was defined as a cold that they shouldn't have taken in the first place, or maybe they were taking macrolide, a Z-Pak for something, or taking Levaquin or some other kind of drug, or maybe because they're alcoholic and we didn't understand that, or they're immunosuppressed. And different areas of the world have different kinds of resistant patterns. So if we look at Mycoplasma pneumonia, well, the resistance in Germany to the antibiotics we use is about 3%, but in Japan it's 30%, and in China it's 95%. Here in the United States ranges anywhere between about 5 and 13%, depending on where you go. Now, the idea about people with viral pneumonia, maybe we treat them with Tamiflu or other neuraminidase inhibitors. It's controversial, and it really isn't all that great under the best of circumstances. For prevention, well, we can prevent the strep pneumonia. That's with the vaccine. You can watch our show on that. Then there hopefully will be a vaccine against the coronavirus. That won't be out till at least mid-2021. What's the mortality again? Mortality is considerably less than 5% in people who are treated as outpatients, but it can go as high as 40 to 50% in people who need intensive care. And that's the story of pneumonia. It's an infection of the lungs. We can't find the cause in about 50% of the cases. In the old-fashioned times, it was almost always due to strep pneumonia, but now it's more commonly due to Chlamydia and Mycoplasma and Legionella, because we're vaccinating against the strep. Now, oftentimes, it's as likely to be due to a virus as it is to a bacteria. And now we have to be concerned, well, is it the coronavirus? That's on everyone's mind nowadays. But also, it could be the influenza virus, the RSV virus, the rhinovirus, adenovirus, and a whole lot of other viruses. And we have a special problem, of course, with people who are very young, less than age 5, or the elderly and people who have compounding medical conditions, people who have diabetes, obesity, compromised immune system. And that sort of dictates our treatment. So it's not just simply take the penicillin or take the amoxicillin or take the ampicillin. There's a lot more to pneumonia than that. Anyway, thanks for watching. If you enjoyed the show, please consider subscribing, and you should tell a friend. And then hopefully, if you subscribe, you'll get information as we post new videos. Anyway, I appreciate your interest. I'm Dr. Ken Landau.